Patty?
Welcome, Dr. Marcus. Thank you so much for kindly accepting the offer to present at our hospital grand rounds, sharing your expertise on a disease that many might not be aware of. So if you don't mind, it's if we give maybe 1 or 2 more minutes, if we can begin, okay?
Yeah, just let me know.
Thank you. Again, thank you, Dr. Marcus, and to be respectful of your time, by my watch here, it's 12:02. So please introduce yourself. I'm hoping a few more will be able to join us in the next few minutes, but go ahead and start.
Okay, thanks. So, well, we have a small group, but I'm always happy to talk about Chagas disease to anybody who's willing to listen. So I'm Rachel Marcus, and I'm the medical director of the Latin American Society of Chagas, which is a nonprofit that works in the metropolitan Washington, D.C. area with Latin American immigrants who are at risk for or have Chagas disease. My day job is to be an echocardiographer in the MedStar system. And I've been doing this work with the immigrant community in the DC area for about 8 years now, and it's been incredibly rewarding. But one of my main jobs is to try to reach out to medical professionals to convince them that they actually are seeing Chagas disease and that there are reasons why they should try to make the diagnosis. So that's why my talk is entitled Chagas disease. It's not the zebra you might think. And this is an interesting hybrid of a zebra and a horse. And so I'm hoping that when you hear hoofbeats, that you might think about either a zorse or a hebra, whatever you want to call this animal. That Chagas disease, I can't tell you it's an incredibly common disease, but I can tell you it's way more common than we think. So start with the disclosures. Don't have anything to disclose. And this is the CME event number. Okay, I thought I would start with a patient testimonial, and you have my very cursory closed captioning skills with this, but this is really an important illness to recognize, and you're going to hear directly from this man, Carlos, about why it is so important.
Y tengo 48 años de edad. He sufrido mucho acerca del corazón, y luego fui al médico y me detectaron que el corazón necesitaba un trasplante de corazón, pero mientras eso esperé un órgano.
I don't know if this breed is chastity.
El órgano, estuve con un aparato para sobrevivir.
The mail just came.
Luego cuando salió el donante, entonces me lo puse.
Oops, sorry, that's I cut off the end of his talking. In any event, he's doing very well after his transplant, but you can hear that his life was really incredibly altered by this disease. So my goals for today are to reacquaint you with this fascinating disease and to convince you that you'll see it if you look for it, talk a little bit about who you might screen, and to update you about current recommendations for therapy. I put this map up here because it's a really nice graphic depiction of where people used to think Chagas disease was in the world and where there's a more contemporary understanding of where the disease is now. So it used to be thought that it was a disease of Latin America, non-island countries, these countries here in red. But then there have been massive population shifts out of these countries in red all over the world, particularly to North America, to Western Europe, Australia, and Japan. And so now, in addition to the countries in red where there is endemic disease, There are also the countries in green where there's disease that's associated with immigration. So the immigrants are born in Latin America, they get the disease there, and then they move to these other countries. And then there's the country in blue, which is obviously the United States, where not only do we have immigrants who have the disease, but we actually also have some disease that's acquired in the United States. Particularly in the desert Southwest, there are actually quite a few of the insects that cause the disease. I would say that almost all of the patients that I work with, actually I really should say all, are Latin American immigrants, and that really is the most important group to be concerned about Chagas disease, but it wouldn't be fair to say that there's no disease in the United States that's occurred because of endemic transmission here. So what did we learn about in medical school? Well, what I learned was that it was a parasitic infection that causes long-term heart and gastrointestinal damage that's chiefly transmitted by rejuvenated bugs or triatomine insects to a mammalian host. And there are over 100 reservoirs known. And that's actually particularly important in the United States because there's actually a canine epidemic in Texas. While it's not much of an issue in humans, it seems, in dogs it really is. So, and it also means it's not entirely eradicable because there are so many non-human hosts where the disease can be found. And it's traditionally thought of as a disease of rural poverty in which a domiciled nocturnal bug will feed on sleeping victims. They live in cracks and crevices of poorly built houses and chicken coops. So these are some examples of the kinds of houses that my patients might have grown up in. So you can see that they're very poorly plastered, that they might have palm frond roofs, and they might even not have much in the way of walls, and domestic animals can wander in or out, which, as we've already talked about, means that other animals with the disease can actually be in close proximity and perpetuate the transmission cycle. And this is an example of where the bugs might hide during the day. You can see somebody pulled down one of the pieces of plaster here in the house, and this is what the insects look like. This is actually their fecal matter streaked on the walls. Now the bug goes by a variety of names. It's known as the kissing bug, and you've probably heard about it here in the United States because it's gotten a lot of press recently. And in Latin American countries, it seems to have a different name almost in every country, which can sometimes complicate asking people if they've ever seen the bug because it has so many different names, but they include insect. And you can see that they're really all over South America, Central America, and up to the bottom half of the United States. And they have been at this point reported, I think, in every state in the southern half of the United States. So this is what the bug does. This is one of these triatomine insects. It's about the size of a quarter, and you can see that its proboscis is stuck through the skin. It's got an anesthetic on it, so most people don't report a particularly painful bite. It has a blood meal that lasts for about 15 to 20 minutes, and then the ones that in Central and South America have a pretty quick gastrocolic reflex, and so they actually evacuate while they're feeding. And so this is actually infected fecal material down here in the lower left, and this is the way that the infection is actually transmitted. So there's parasite infection of the fecal matter, and then the human is the one who generally does the job of moving this infected fecal material either to the bite wound or into the eye, because often this bug bites on the face, and that's the way that the parasite gains access to the bloodstream. And this is what the parasite looks like. Carlos Chagas named it after his mentor, Oswaldo Cruz. And there are at least 6 different strains, with Trypanosoma cruzi 1 and Trypanosoma cruzi 2 being the main strains, and then there's substrains. And this may matter a little bit in disease virulence. This is what it looks like in the heart. The parasite then basically travels from the bite wound throughout the bloodstream, and this is a cluster of mastigotes, which is part of the parasite life cycle that's stuck in the smooth muscle cells in the heart, and it also does the same thing in the smooth muscle cells that line the intestines, and it likes autonomic nerve termini as well. The pathophysiology, well, I focus mostly on the cardiac pathophysiology, both because it's the most dangerous, but also because I'm a cardiologist. Basically, Chagas disease is a chronic subclinical lymphocytic myocarditis. And what you can see is that there's parasite persistence in the heart, actually in perpetuity unless somebody's been treated. And there's lymphocytes around the parasite and direct parasite toxicity. There are also microvascular abnormalities with intimal proliferation and arteritis, abnormal vasodilatation, and watershed ischemia. There are autonomic derangements, in part because the parasite does have a tropism for autonomic nerve termini, and immune-mediated injury, meaning autoantibodies that are, I think, some at least to beta adrenergic receptors. And basically all of these different mechanisms coalesce to cause myocardial damage and fibrosis, leading to the cardiac disease. So this is an example of some gross pathologic specimens and one histopathologic specimen that actually really does a lot of work explaining to us how the disease manifests clinically. So this is a heart of somebody with Chagas disease where the left ventricle is very, very dilated, and there's an arrow pointing towards the apex where you see both scar as well as thrombosis. So this is a patient who might have died from heart failure, but this also reminds us that Chagas disease is an incredibly thrombogenic illness, so they may also have had strokes as well. And in comparison to other cardiomyopathies, there's actually significantly more strokes, which is one of the reasons I feel so strongly that we should make the diagnosis. This is a different heart where you can see that the heart muscle is more hypertrophied, but there's very focal apical scarring. And this is a reminder to me both that there is thrombogenesis in Chagas disease because this focal scar can lead to an aneurysm, a very focal aneurysm that can cause thrombosis, but also that you don't need to have a terrible heart in order for that to happen. So this patient could very easily have had a normal myocardium and a normal myocardial function, a normal ejection fraction, but still have had a stroke from Chagas disease, which is very unusual in any other sort of cardiomyopathic condition. This heart here has normal myocardium down towards the bottom, but you can see the arrow is pointing to very focal thinning of the myocardium here at the basal inferolateral wall. This, unfortunately, is highly associated with arrhythmia, including lethal ventricular arrhythmias. And this is another reminder that, in fact, these patients with Chagas disease can be at risk for catastrophic complications, i.e. sudden death, even when their ejection fractions are normal. Again, something that's not typical for most other cardiac conditions and cardiomyopathies. And this last picture here is histopathologic specimen from the His-Purkinje system, which shows intense focal fibrosis. And this is a reminder that we not only get tachyarrhythmias with Chagas disease, but also bradyarrhythmias, and these patients can present with heart block. So what's the clinical course of Chagas disease? Well, this first part of the clinical course is called the acute phase, and I'm going to speak specifically about the acute phase after somebody's been bitten by one of the rejuvenated bugs, the triatomine insects. This generally would happen in childhood, and it's a very nonspecific illness, which means that most of my patients don't really recall the time that they had Chagas disease, in part because it also potentially happened over and over again, so there wasn't one critical episode where they had it, but also just in general, it doesn't really seem like a particularly notable illness. Fever, malaise can occur, adenopathy. It can last for a little bit longer than a typical febrile illness, so it should be considered as on the list of FUO diagnoses. This gal on the right has something called Romagn's sign. This is painless induration of the palpebral tissue that's thought to be due to inoculation with infected parasitic material in the feces of the insect. It can last for several weeks and is thought to be pathognomonic, although it may actually also just be an allergic reaction to the feces itself rather than to the parasite. About 2 to 5% of people will have a clinically important presentation with myocarditis and meningoencephalitis, and about 10% that can be fatal. And if you were to examine a blood specimen, you'd find parasitemia in almost all patients, and antiparasitic medications are effective for cure in about 70 to 90% of patients who are treated at this phase. In the United States, we're not really likely to see this particular form of the disease, although there have actually been some case reports both in Missouri and in Texas of people where a very acute clinician has made the diagnosis. So it's not unheard of, it's just extremely rare. Where we might see a different kinds of acute presentation would be congenital Chagas, in which there is maternal fetal transmission. It's in about probably 3% of pregnancies in non-endemic countries. Most often the babies are asymptomatic, but in 10 to 40%, they can be premature, have hepatosplenomegaly, anemia, and hydrops. So that might be a time when we would see an acute presentation in the US. We also might see it in reactivation, which can either occur because of disease-induced immunosuppression, i.e. HIV or malignancies, in which case the patients actually can have neurologic manifestations. And in HIV in particular, it looks an awful lot like toxoplasmosis, in which case, if the patient doesn't receive the appropriate therapy for trypanosomal infection, they will die because it's a lethal illness. But if it's recognized that it's not toxo and it is Chagas instead, then an appropriate antiparasitic therapy is curative. There's also medication-induced reactivation, including transplant regimens, immunosuppression, and that tends to cause skin and cardiac disease if it's unrecognized. Not so much in the United States. There have been some outbreaks associated with oral consumption in general when a parasite has been ground into a juice that's not been pasteurized. This causes a fairly lethal illness. It's very fulminant. But again, not something you'd be likely to see here unless you happen to see a returning traveler from a tropical region who'd gotten sick there. And then it can be transmitted via transfusion. In the United States now, every first-time blood donor is screened for Chagas disease. So it's extremely unlikely to happen here. But unfortunately, there's some UNOS networks that don't screen for Chagas in their donor pool. And there was a recent case of a recipient of a heart who died from fulminant trypanosomiasis. So if you don't get treated in your acute phase, almost everybody is thought to pass into the indeterminate phase of the illness, in which there basically are positive serologic tests for Chagas disease, but no end organ manifestations. And the diagnosis of Chagas, I should say, is dependent on having 2 positive serologic tests. It means you can have 2 ELISAs, for instance, but they need to be from different antigens, or an ELISA and a different serologic assay. Right now, what that means practically is that you get if you're going to order the test here, you order it from your commercial lab, and then if it comes back positive, you send the blood to the CDC for confirmatory testing. Now, because you're in Maryland, you're in the only state that actually has a slightly different possibility for testing, which is if you send your blood sample to the State Department of Health, they will actually run the assay for free. They'll run the initial ELISA, and then they will actually have a reflex to send the blood to the CDC if that ELISA is positive. So it really is a pretty amazing thing in Maryland. This guy here off to the right is having something called xenodiagnosis done. It used to be that the NIH had a lab where you could do this, but it's really not something you could order in the United States now. What it is he's got laboratory bred triatamine insects in those cups on his arms, and they're feeding, so they're having their blood meal. They then go back to the lab where they're fed chicken blood, because chickens don't get Chagas disease. And after a few weeks, they're sacrificed, and people investigate the contents of their intestines. And if there's parasite in their intestines, it must have come from the patient upon whom they fed. This is called xenodiagnosis, and it can be positive in up to 50% of people who are chronically infected. The great news about Chagas disease is that this is the final phase of the disease for most of the people who are infected with the parasite. About 70 to 80% of patients will not progress to any further organ damage or toxicity. Unfortunately, 2 to 5% of patients per year will progress, and there are a certain proportion of people who disease that manifests after about 15 to 30 years, which is called the chronic phase of the illness. And as I said, it's 15 to 30 years after likely infection, which means that frequently these individuals are presenting in early to mid adulthood, which is slightly younger than they would say if they'd had coronary disease. So it's a young patient population. It's not clear why this happens, although men have more significant cardiac impairment than women, it seemed in studies. It may be due to the degree of parasitemia, to reinfection rates, manual labor, strain type, genetic factors in the immune response. People aren't really sure. And gastrointestinal manifestations occur in about 10% of people. It's more common in South America. And we'll talk about that briefly later. So what are the symptoms of the chronic phase? The cardiac disease presents with angina-like chest pain from microvascular disease, exertional intolerance from chronotropic incompetence or from heart failure, palpitations and syncope from autonomic issues, bradyarrhythmias or tachyarrhythmias, heart failure from LV or RV dysfunction or both, and stroke. And as we discussed, this can be due to that focal apical aneurysm, so even in patients who have basically normal LV function, but also because Chagas patients have more atrial fibrillation. The cause of death is 50% sudden cardiac death, 40% heart failure, and 10% from embolic phenomenon. So let's say you decided to test your patient and they were confirmed positive for Chagas disease. What would you do next? Well, the first thing you would do is an EKG with a 30-second rhythm strip. And this is the main diagnostic criteria for chronic phase. So if your patient has a normal EKG, they're indeterminate phase. If they have an abnormal EKG, they're felt to be in the chronic phase of the illness. And what you're looking for are signs of the conduction system disease that we talked about, and signs for arrhythmogenicity. So things like sinus node dysfunction, PR prolongation, right bundle branch block. And I'll show you this graph from a meta-analysis of EKG findings. I think there were 49 studies and over 34,000 patients that were included in this paper. And they found these EKG abnormalities to be significantly associated with Chagas disease. They include the things that we talked about, right bundle branch block, left anterior fascicular block, first degree AV block, AFib, and ventricular extrasystoles. One thing, though, that people have sometimes taken away from my talks, because I haven't been clear enough about it, is that these are the EKG findings that you must see in Chagas disease, and if your patient doesn't have them, it's not Chagas. Well, that's not really true. There are other EKGs findings that can be found in Chagas disease. So just because your patient doesn't have these doesn't mean that they don't have Chagas cardiomyopathy. It's just these are the ones that are the most strongly associated with it. And this is an example of that from 2 different studies that looked at patients with heart failure. So these are patients who actually had advanced cardiac disease. And what you can see is that this is the Chagas group here, and this is these patients here have other non-ischemic cardiomyopathies. So in patients with heart failure, 50% of the Chagas patients had bifascicular block, whereas only 5% of the patients with non-ischemic cardiomyopathy of other reasons did. By the same token, 10% of Chagas patients had left bundle branch blocks, but 51% of the other people did. So what that's saying here, again, is that just because you have a left bundle branch block doesn't mean you don't have Chagas. It's just a more uncommon finding. And the same thing is true here at this second database down here. I won't spend any more time on it. So, and this is just my way of reminding you that when you see the hoofbeats of a bifascicular block, you ought to be thinking about Chagas disease. So another test that you will do if somebody has an abnormal EKG is a Holter monitor, just to look for any subclinical manifestations of either bradyarrhythmias or tachyarrhythmias. It's not really necessary in somebody who's got normal cardiac exams and no symptoms. And then we move into the more advanced imaging modalities. Right now, there's a little bit of controversy about whether or not every Chagas patient should get an echo. And I really feel pretty strongly as part of this group here that they should. And in part, that's because even though patients may have normal EKGs, there's a very small number of them who will have abnormalities on echocardiogram anyway. And to me, that's a patient who deserves a more careful follow-up. So this is just a table that came from a wonderful paper in circulation by an echo expert in Chagas disease, looking at some of the hallmark findings for Chagas disease on echo. And basically what he did was he stratified them across the clinical stage of the disease. So there's stage A, stage B, stage C, and stage D. A is basically normal EKG, no symptoms. B is abnormal EKG, no symptoms. C is abnormal EKG, abnormal echo and symptoms, and D is stage 4 cardiomyopathy. And what you see are there are these unusual findings for Chagas disease, including the left ventricular aneurysm, the left ventricular posteral basal lesion, which I showed you, a posteral basal lesion, which I showed you where the scar was that causes the arrhythmia. And then basically as you move across the stages, the rates of these abnormal findings get higher and higher, the ejection fraction drops, and survival decreases pretty dramatically. So this is an example of an echocardiogram in a patient with Chagas disease. This is an immigrant, an El Salvadorian immigrant who presented to Georgetown Clinic because of palpitations, and he was found to have bifascicular block on his EKG. Because of that, he had an echocardiogram, and this really looks absolutely normal, but we haven't really looked at the apex very clearly. Unfortunately, when he came back after a massive middle cerebral aneurysm stroke, he received an echocardiogram with echo contrast, and you can see a very focal bright spot here at his apex, which is the saccular aneurysm associated with Chagas disease. And it was because of this that he had a truly devastating and truly life-altering stroke. So one of the things that I tell my cardiology colleagues is if they're ever thinking about Chagas disease and getting an echo, that we have to do a very careful job of looking at the apex to make sure that we're not missing something like this. And that includes adding echo contrast to our echo. There's also MRI. Now, this isn't quite so easy to get in a resource-poor environment, and most of the people that I work with are uninsured, so it can be tricky sometimes to get this testing. But there's a lot of association between Chagas disease, particularly as it advances with late gadolinium enhancement. It's also true that patients with normal EKGs can have scar in up to 40% of cases. And to my mind, we don't really know yet what the prognostic significance of that is, but I don't think it can be good. What we do know is the magnitude of scars associated with worse outcomes, and that there may be a role in risk stratification for defibrillator placement, particularly in patients who have EFs that's not particularly bad, but not normal. And you wouldn't necessarily put a defibrillator in, but if they have a lot of scar on their MRI, you might consider having them have an EP study and getting a primary prevention defibrillator. So this is just some examples of gadolinium uptake in a variety of patterns from an MRI, a paper in the Journal of American College of Cardiology from 2018. And this is an MRI on that same patient that I just showed you the echo of, the young man who had the stroke. And you can see here on the moving images that he has a little bulging aneurysm at his apex. And this bright line here is the gadolinium uptake in the skull at the apex. I like to show this one too. This is not from DC, this is from Chicago. This was a Mexican immigrant, a 44-year-old man who had a sudden death event. And basically this entire area of his heart looks like a hammerhead shark head. So a huge apical aneurysm from Chagas disease. And this was what made the doctor think about Chagas disease. They saw this finding and they realized that it was very unusual, particularly in a patient who did not have coronary disease. And that triggered them to reach out to me to make the diagnosis. Unfortunately, Chagas cardiomyopathy is actually a really bad disease, and it's worse than many of the other cardiomyopathies to which it's been compared. So this is true even in the era of guideline-directed medical therapy. These are patients from the Paradigm Heart Failure Atmosphere database. All of these patients receive state-of-the-art medical care. And the Chagas patients in red, you can see, have higher mortality than both other non-ischemic cardiomyopathies and ischemic cardiomyopathies. So it's really, really a bad disease. Just to shift gears really quickly to talk about the gastrointestinal illness, which I don't speak as much about. The two main hallmark findings are megaesophagus and megacolon, and this is thought to be due to disruption of the autonomic plexuses and smooth muscle cells in the lining of the viscera. Megaesophagus really presents very much like achalasia, and you can see this barium esophagram right here, where there can be food retention and people coughing up food and having aspiration pneumonias. It's treated very much like achalasia, and also the imaging tests are also similar to what you would use for achalasia. The other one is megacolon, and this is, you can see a fecaloma inside this giant colon here. This is, in general, we treat this conservatively, although these patients can actually have pressure ulcers from fecaliths and become septic from that, and there's also can have torsion. So surgical repair of a giant colon is actually sometimes required. So how do you treat your patient? Once you've done all of your analyses, what do you do? So the first question that people ask is, well, is there any antiparasitic therapy that's helpful? And there is one FDA-approved medication in the United States for the treatment of Chagas disease. It's a very old medication. It's been around for about 40 years, and it's called benznidazole. It needs to be 90% of people will be able to finish the therapy, and it's really unpleasant. So almost everybody has some kind of a side effect or another. The one that's the most worrisome is the one that I bolded, which is the rash. People can have a macular-papular drug eruption that can be treated pretty well with antihistamines and temporary drug cessation. But if it's left unchecked, it can evolve sometimes into either an angioedematous picture or even very rarely a bullous skin reaction. So patients who I treat, I want to make sure they're going to be able to come in for their follow-up appointments, and I really watch them like a hawk just because the complications can be devastating. So what's the data for treatment? That doesn't sound like such a great medication. How strongly should we try to think about prescribing it? Well, so seronegativization is associated very strongly with therapy in children, and particularly in neonates. So if you can find somebody who's young, recently infected, it's a really, really good indication for therapy. And fortunately, in the young, the side effect rates seem to be much lower. There's observational data, and it is only observational data, but really remarkable decrease in the risk of transplacental passage in women of childbearing age associated with therapy. So we try to focus our efforts on trying to find women who may be planning future pregnancies to see if we can help with that, although, again, observational data alone. There is only prospective trial data that shows a decrease in risk of progression to cardiac disease associated with treatment in adults, although they do seronegativize when given the medication, although with much lower rates than children, and also it takes much longer. And then the one area in which there has been a really big randomized control trial is people who've got established cardiac disease. And part of the reason that we don't have much in the way of data here is because most of the people who have Chagas disease have lived in resource-poor environments. There's not been a lot of drug company interest in developing new medical therapies. So that's been one of the things that's plagued this field. But this study was done in Latin America, and there were 2,854 patients who were randomized to benznidazole or placebo. They were a slightly older group in that the mean age was 55, and at both 5 and 7 years, there was no benefit in terms of hard cardiac endpoints associated with benznidazole therapy. This was called the BENEFIT trial. And this was in spite of the fact that the medication caused dramatic reduction in PCR positivity in patients who were treated. So it's led some people to believe that maybe there's some decoupling between whether or not the parasites are around or active and the manifestations of the disease, but we just don't really know the answer yet. In any event, what this led me to believe is that if I'm dealing with a person who is within 2 standard deviations of the mean of the age of 55, that I'd probably want to think twice before I would give them benznidazole therapy. That patient who was 25 or 27 when he presented with his stroke, we actually elected to treat with benznidazole just because he was so young. Of course, within the absence of any data that really made us confident that we would be helping him, but he tolerated it well. So what else can you do? If you can't treat people with antiparasitic therapy, then why does making the diagnosis matter at all? It's just the same as any other heart problem. Well, in some ways, we use similar treatments for other heart problems. And some of it is we've had to extrapolate because of what I already explained about resource poor environments. There's not a lot of large scale studies that have tested these medications specifically in Chagas patients, but we use the standards. We use the ACE inhibitors, the ARBs, valsartan, sacubitril, aldosterone antagonists, beta blockers. Beta blockers is a little interesting just because we've had a discussion already about the bradyarrhythmia that's associated with this disease, and people worry that beta blockers might actually exacerbate it. But it turns out that you can get beta blockers onto a pretty good proportion of your patients, even if it's slightly lower doses. One of the confounding issues there, though, is that in Latin America, a lot of these patients are getting amiodarone to treat their ventricular arrhythmias because it's a little hard to come by defibrillators. And amiodarone powerfully reduces the heart rate. So that may be part of the reason why it's harder to get patients onto optimal beta blocker doses. Amiodarone may also have antiparasitic activity, and so it's actually been studied in this particular regard. So what else do we do for these patients? Well, we have electrophysiology options, including pacemakers and defibrillators. And one of the reasons I put this echo up here is that this is a patient that I saw at Washington Hospital Center who was a 45-year-old El Salvadorian immigrant who had a sudden death event. And this is an echo that he had after being in the hospital for about a week. And his ejection fraction is actually really not bad. I think it was about 50%. So obviously for this particular man, he's going to get a defibrillator. And he'd had this EF. We would not have worried too much about him if we hadn't known about the Chagas disease. Well, in fact, in spite of the fact that his EF looks okay, he does have significant scarring on MRI. So it's a reminder that this is one of the reasons why we want to know about this disease, because even patients who don't have terrible ejection fractions, we have to really strongly think about whether or not they should be candidates for defibrillator therapy regardless. And then there's the thromboembolic disease. So this is a patient here who is another patient we saw at Washington Hospital Center, who's a 72-year-old woman from El Salvador who actually presented with heart failure. And this echocardiogram was obtained, and this patient has a bad heart, but also a massive LV apical thrombus. So this patient's not like the one before. This is one where her ejection fraction is actually pretty bad, so it's not quite as much of a surprise that she would have this. But one of the reasons to make the diagnosis of Chagas disease again is because these patients are at such high risk for having these thromboembolic events, and it makes us need to think differently about whether or not we might even give them primary prevention anticoagulation. Unfortunately, this isn't really greatly supported by any evidence. It's not that there's evidence to the contrary, it's just that it hasn't been studied well. But some researchers in Brazil came up with something like the ChagasDisease system to try and figure out whether or not we could come up with a score that would indicate a need for primary prevention. And this patient here, even if she didn't have the big clot already, probably would need it in that her age is over 48. She's got left ventricular dysfunction. She has an apical aneurysm, and she's got repolarization abnormalities on her EKG. So she would get points for all of those, at which point the scoring system database would suggest that she would benefit from primary prevention. And she parenthetically had evidence of subclinical infarcts on head CT. So another reason to make the diagnosis is that we have to think very carefully about this risk, and also We're very scrupulous when we evaluate the apex of these patients. So another therapy that we can provide for people is heart transplant. And it's not obvious necessarily that that would be a great idea, because if you immunosuppress somebody with this illness, we've already talked about the fact that they can reactivate. Well, it happens. And in the United States, on our current immunosuppressive regimens, it happens quite frequently, as the CDC has been following most of the patients, if not all, who've been knowingly transplanted with patients with Chagas disease who've been transplanted, and 60% of them had PCR evidence of reactivation in the immediate post-transplant period. The great news is that they respond really well to benzimidazole therapy, and because in general they seem to be younger and have less comorbidity, they actually do really well. So that's a very good thing. And unfortunately, many of the patients that I see, because of their immigration status, are not eligible for this. But should you have a patient who is able or ineligible for advanced heart failure therapy, they certainly can benefit from this if needed. So here we are back with our zebras and our horses. And basically, this part of my talk, I want to convince you that actually you might see this. So a lot of people will say to me, I've never seen a case. And I like to remind them a little bit about some of the demographics of the immigrant community in the United States. So 18% about of US citizens identify as Hispanic according to the US Census, and 34% of them are foreign-born. Using data based on country of origin and the prevalence of Chagas disease in the country of origin, the CDC estimates that there are about 300,000 cases of Chagas disease in the United States, with 40 to 50,000 cardiac cases, and 63 to 315 congenital births a year, which actually makes this as common as some of the inborn errors of metabolism that we routinely screen for in every neonate, if you were to look only in Latin American moms. So there's also some data from in the United States now, which is pretty impressive, coming out of the LA County Olive View Medical Center, the Center of Excellence for Chagas disease. Doctors there screened their heart failure population, patients with non-ischemic cardiomyopathy, and found that almost 19% of the patients that they screened had Chagas disease as the cause of their left ventricular dysfunction. They also looked at patients who were from Latin American endemic countries, looked at their EKGs, if they had abnormal EKGs, and screened them for Chagas, and found that 5% of all bundle branch blocks, 18% of bivesicular blocks, and 7.5% of patients who had pacemakers had Chagas disease as the cause of their conduction system disease. And then they performed a really wonderful 4,000, almost 800 community-based screening program, and found an overall rate of about 1.24% seropositivity, but higher rates in El Salvador of up to 3.5%. And that's really important for us because we'll talk about the nature of the immigrant community in the DC area, but it's really quite unique. This is another study that actually looked at an immigration population that's really more similar to ours out of East Boston. At the time that they wrote this abstract, they screened about 5,000 patients. It's now up to 8,000, and 1% of those patients have screened positive for Chagas disease. I pulled out this particular graph because it really is the story of my life. One of the difficulties with Chagas disease, though, is the real structural barriers for patients even getting the testing to begin with, but also following through with what they need afterwards. So for 100 patients that they tested positive with Chagas disease, 94% of them were referred, 74 were evaluated, 38 initiated therapy, and only 20 completed therapy. So you can see just massive dropout rates here. And a lot of this has to do with access to care, low healthcare literacy, language barriers, poverty, things like that. So it really can be a struggle. So we'll talk a little bit about our immigrant community. I'm sure that you all are very familiar with this as well, but we have about a little over 1 million people in the DC area who identify as being Hispanic or Latino, the 2018 ACS survey. And we have higher than the national average rate of foreign-born individuals in around 40 to 45%, depending on the state. Most of them actually are from El Salvador. So we've already seen that that's a higher than average risk of having Chagas disease. And we also have Little Bolivia. It tends to be concentrated in Northern Virginia, but also in Montgomery County. And these Bolivians tend to come from areas of Bolivia where Chagas disease is highly endemic. So I participated with Johns Hopkins Research Group on a seroprevalence survey in the metropolitan Washington area, We screened about 1,500 people, and there was overall 4% seroprevalence rate in all of the immigrants we screened, but 20% of the Bolivians had Chagas disease. This is somewhat of a convenient sample because people who know about Chagas disease are probably more likely to want to get screened, and the Bolivians have a lot of literacy around Chagas disease because it's so common there. So we definitely, I think, screen people who are more likely to have it, but still 20% is a crazy high number. And this is the area of the country where we have the two publicized cases of congenital Chagas disease, both from Bolivian moms. So I think Chagas disease really is a big issue here. So what do I want you to do with that? So what I would like for you to do is to start screening for Chagas disease. And there are a number of different ways to approach it. One would be to screen every Latin American immigrant from a Chagas endemic country. And I think actually people who practice in Maryland are uniquely situated to do this with as little annoyance as possible because the Maryland Department of Public Health will screen for free. But that's a big ask. And so frequently what I end up doing is trying to hone down the target population where I think it's really worth knowing. And that would be in the cardiac setting, any patient who exhibits any of the signs of Chagas disease for the reasons that I've told you. I think it really makes a lot of sense to think about screening in women of childbearing age, just because we believe, even if it's observational data only, that if you treat, you can reduce the risk of maternal fetal transmission. And also, if mom is positive, all of her children should be screened. And we know that treating children, the sooner you can treat someone, the better in terms of their long-term chances of being seronegative for the disease. So with that, I will open the floor to any questions. Actually, this is just, shouldn't have said that so soon. This is just a really nice sort of flow chart for how to deal with Chagas disease that came out of a paper in JACC. I put it up as a reference. And now I will thank you and open up the floor for any questions. And thanks for your attention.
I see, this is Patty. I see Dr. Grossberg is on the call. He's one of our very well-known cardiologists. So that was good. And Dr. Grossberg, do you have any questions? Did you ever see any patients in your practice?
Not in Maryland, but in actually in New York.
Where were you practicing there?
Oh, I was in medical school and also in suburban Jersey, which had some Salvadorans in the population. That was in the early 80s. But in any case, I had a question, if I can ask, please.
Yeah.
I'd like some clarity on the patients who I guess are still seropositive. They have the cardiomyopathy manifestations, and if they don't get the diagnosis and i.e. the treatment, but they get the therapies, and even if they come to transplant or what have you, what happens to the risk of, as you said, reconversion? Or I would think you would have to have treatment to have success in the transplant. Or
so it's a great question. The way that we've settled it in the US, and I think it's tends to be true now worldwide, is that because the risk of reactivation is not 100%, and because people prior to transplant tend to be sick enough that they would poorly tolerate the side effects from benznidazole therapy, that we do proactive surveillance for reactivation and jump on it as soon as we see it. So in the US, we define reactivation not really as a clinical syndrome, but as a lab test marker. So starting about a week out from transplant, you send serial PCR samples to the CDC and also do a buffy coat microscopy. And if you see parasite on buffy coat, or if the PCR from 1 week to the next has a more rapid amplification time, then you define that as presence of parasitemia and treat. And because of that, we aren't letting people actually establish a significant reinfection and are catching them at a time when it really actually works very well. So since the time
1 week pre-transplant or 1 week post-transplant?
Post, yeah. So the practice really isn't to treat beforehand. And part of the reason, I can share with you a little bit of anecdote, but part of the reason is that benznidazole therapy isn't great. And one of the 3 transplants that I was involved with at hospital center over since the time I've been working on this had actually been treated prior to transplant, and he reactivated within 2 weeks of being transplanted. So just because you've been treated doesn't guarantee. And a lot of it is that these are intracellular parasites, and it's not even really clear that we know how to administer the drug. I mean, there's a lot of controversy about even what to do with benznidazole. So for right now here, that's how the consensus in the transplant community, which seems to work pretty well. The bigger issue, say, is in suburban New Jersey at the time, about a year ago, maybe 2 years ago now, a patient received a donor heart that was Chagas, that had T. cruzi infection. And by the time they realized that the patient had fulminant trypanosomal infection, he was so critically ill that he perished. So that's a little bit more problematic. But for now,
He received a normal ejection fraction, but acutely infected patient's heart.
That patient, I remember the majority of the manifestations for him was actually neurologic. He had meningoencephalitis. Yeah, but patients can actually develop a myocarditis if you didn't catch them before they develop clinical manifestations. They can either develop this odd paniculitis, where if you biopsy skin, you'll see trypanosomes in the skin, or they can develop cardiac disease, or they can develop the meningoencephalitis as part of their reactivation picture.
Fascinating. Thank you.
Yeah.
Anybody have any other questions? Okay, well, Dr. Marcus, I just want to thank you on behalf of Holy Cross Health. That was really for sharing your expertise. It's so interesting. And we hope you come back soon.
Anytime.
All right.
Appreciate your time. Okay.
Thank you so much. You have a great day.
Thanks very much.